Hi, everyone. Welcome to today's CLL webinar brought to you by HealthTree Foundation. My name is Megan Heaps, and I'm the CLL Education Manager at HealthTree. I'm very grateful to have each of you here today and for your support in building this CLL community. I'd like to let you know that today's session will be recorded, and the recording, along with any resources we discussed today, will be sent via email to all registrants within 48 hours after the event has concluded. We'll start with a brief Zoom meeting tutorial for those that are new to the platform. We would love for all of you to turn on and keep your cameras on if you feel comfortable. Doing so helps us create a stronger sense of community. You can see on the slide how to turn on your camera. At the bottom of your screen, you should see the microphone and camera buttons. You can click the video icon that says Start Video in order to turn your camera on. With that being said, if you're not comfortable being recorded, you're not required to keep your camera on. Your microphones should be currently off and will be kept off by our team throughout the presentation. During the group discussion, you're welcome to unmute yourself once you're called upon. If you have questions or comments for us or for our speaker throughout their presentation, please click the chat icon and type them in the chat box. If you're using a mobile device or tablet, click the three-dot icon that says More and then Chat in order to access the chat box. And lastly, if you would prefer to verbally ask a question or make a comment directly to our speaker during the discussion time at the end, we encourage you to do so. If you're using a laptop or desktop computer, click Reactions near the bottom of your screen and then click Raise Hand. If you're using a mobile device or tablet, you can click the three horizontal dots that say More and then click the Raise Hand button. Now let's get started with today's event. First, I'd like to thank our sponsors who make events like this possible, AbbVie and Genentech. The topic of our event today is relapsed refractory CLL treatment options. Here's the agenda for today. I'll introduce our speaker, Dr. Kerry Rogers. Dr. Rogers will then spend the next 30 minutes or so giving us her presentation. After the presentation, we will open it up for your questions and comments. So let me take a moment to introduce our speaker, Dr. Kerry Rogers. Dr. Rogers is a hematologist-oncologist dedicated to advancing the care and treatment of patients with chronic lymphocytic leukemia, or CLL, and autoimmune cytopenias. Following her initial medical education at Chicago Medical School, she completed her residency in internal medicine at the University of Michigan. She then undertook fellowship at The Ohio State University in hematology and oncology. And after completion of her training, she was delighted to join the staff at the OSU CCC James. In addition to clinical work, she spends time teaching medical students and resident physicians as an assistant professor in the Department of Hematology. As a member of the Leukemia Research Program at the OSU CCC James, she conducts research in the Experimental Hematology Laboratory, developing novel therapeutics for autoimmune cytopenias. Her research group has an interest in finding optimal strategies for the use of BTK inhibitors, including studying resistance, combination therapies, and treatment discontinuation. He is currently the principal investigator on 4 open and 2 pending clinical trials in this area, including 2 investigator-sponsored trials and an NCI study. He has written several articles for publication in medical journals such as Leukemia and Cancer Cell, and has prepared numerous abstracts and posters for presentations. What she loves most about the James is working with very passionate and committed team members to give patients the very best care. She feels that communication is a key aspect to providing the best medical care and enjoys spending time with her patients most of all. So with that, I'm going to turn it over to Dr. Rogers.
Hello, everyone. I'm Kerry Rogers. Like she said, I'm a hematologist at The Ohio State University at the James Cancer Hospital. And just so you know, it is raining very hard here in Ohio this afternoon, which not only means my lighting isn't great, but also if I start sneezing, it's because I'm very allergic to outdoor mold. So please don't be alarmed if that happens. That's what happens when you move to a state you're highly allergic to. So I've actually lived here, I think 14 years now, and the allergies don't get any better. So I have prepared a few slides today just to cover this topic of relapse refractory CLL and treatment options. And anyone, if you have questions, can stop me at any time. I'm happy to take questions during the presentation. And then, of course, when I'm done talking, I think we're going to have a question and answer so you can get all your questions answered. And I hope they'll be able to send out the slides after the presentation too. Some of these contain some more technical information, but hopefully they're understandable. And I'm going to try to break it down for everybody because I really think understanding some of this health information um, is really important towards making good health choices too, but just understanding kind of like where the field is key as well. These are my disclosures. So these are companies that I receive either research funding from for clinical trials or companies I consult for. These are mostly companies that make medications used to treat CLL. So just as a general overview of what I'm going to talk about, I'm going to open with just talking about a few basics of CLL so we're all on the same page, and then kind of some definitions about what is relapsed refractory CLL, because this is a word that, doctors use a lot that maybe not everyone understands exactly what that means. Then kind of treatment options after our two main classes of drugs, which are either BTK inhibitors or venetoclax, which is a BCL2 inhibitor. And then what is really important, which is this management of either double exposed or double refractory CLL, and I'm going to define that. And that's really where I think some of the newer drugs that are in development or recently approved have the biggest impact. And then, of course, my favorite part, which is questions and discussion. So I'll try to cover this in about 30 minutes, so there'll be enough time for questions at the end. So everyone probably knows this, but I think it's good just to start on the same page. I don't have a lot of slides about this, but I do want to cover just what CLL is in case anyone's new to this area. So CLL, of course, is a chronic B-cell leukemia, usually diagnosed when asymptomatic and then observed until treatment is needed. We've got multiple studies showing that treating it just because people have it doesn't help people live any longer. But over time, the CLL cells kind of cause problems through three different ways. Either they accumulate in the lymph nodes, the white blood cell count can go up in the blood, which usually is fine, but can increase quickly, which is problematic. It can fill up the bone marrow, causing low blood counts. The cells can actually release something called cytokines, which are chemical mediators. Usually in healthy individuals are released for infections, but remember CLL cells are, it's a cancer of immune system cells, so they can release those mediators, which can make people feel quite terrible. So that can cause night sweats, weight loss, and fatigue, kind of unhealthy amount of fatigue. And then actually CLL cells, their presence disrupts normal immune function, making people living with CLL at higher risk for infections or other cancers. Not all of these can be resolved with treatment. In fact, that last one, which is a higher risk of infection or other cancers, is usually just increased the more treatments people get because the treatments are also suppressive of the immune system a little bit, even targeted ones. And then really, CLL is treated when any of those things become a problem for an individual. So I think it's important to keep that in mind as we're talking about people with CLL that have had prior treatments, is that many people get to spend some time living with CLL before they even are required to have any treatment or something to improve. The other thing that I think is really important is this is some data I pulled fairly recently, I think a month or two ago, from something called SEER, which is a government clearinghouse that tracks cancer statistics in the US population. CLL is the most prevalent leukemia in the Western world. So actually in Asian countries, it's a very rare leukemia, and that's based on kind of the racial background of who gets it. So it's mostly white people that get it. It's not environmental, it's actually genetic. So like Asian people living in the US don't get CLL very often. Median age at diagnosis is about 70. So this means that many people with CLL are older. The good news is we have good treatments even for people who are older. And then the median survival is more than 10 years. So nobody lives forever, and not all the deaths for people that have CLL are directly related to CLL. People do die of other causes. In fact, dying of something other than CLL is quite common. CLL is not life limiting in many cases. So this means that adults are living with CLL for many years. You can see the number of estimated new cases a year. And I do think if you look carefully on the slide there, you've got like this like two lines from SEER, and this is the rate per 100,000 persons. So for people, the green line is the number of new cases, and that dark green line is the number of people or deaths from CLL. And you can see that dark green line keeps going slowly down, right? So you can see it's like just under 2 at the top, and it's like kind of around 1 at the bottom. So that means that since 1992, we're seeing fewer deaths from CLL every year. So that's good. That means that things that we're doing to take care of people with CLL are working and the mortality is decreased. There's also a lot more people diagnosed with it than will die of it every year because people live with this for a long time. So I think that's just a nice way to think about it and to frame what I'm about to discuss. And then the major topic is treatments for relapse refractory CLL. And just so everyone understands what that is, that's CLL previously treated. So it's people that have had a prior treatment for CLL. And then relapsed means that the CLL was treated and then progressed after a remission. And then refractory is usually patients who did not achieve a remission with a treatment, which is very uncommon, or had a progression 6 months after finishing like a completed treatment. So both refer to CLL that returned after treatment, and since, with the exception of some rare cases, we don't consider CLL to be curable, so having a long lifespan with sometimes multiple incidents of the CLL progressing or becoming resistant to a treatment and then taking a new treatment is actually the norm here, because we can't eliminate it entirely, and people do very well for a long time, meaning that they might experience multiple treatments. So the current initial treatment, so this is not like the outline for people that have had a prior treatment, but the current initial scheme is two different options, and these are targeted agents that are our most effective treatments today. One is BTK inhibitors, so those are drugs like ibrutinib, acalabrutinib, and zanubrutinib. Ibrutinib is now a second, this is the NCCN guidelines. It's just like a major guideline in the US that oncologists use to figure out how to treat, a variety of cancers. This is the one for CLL. Ibrutinib is actually less preferred due to the risk of cardiovascular side effects that's not seen with acalabrutinib and zanubrutinib to the same degree. And then the other option is venetoclax and obinutuzumab. So this means that these days, when we're talking about people with relapsed or refractory CLL or previously treated, the probability is they've experienced one of these treatments, either BTK inhibitors or venetoclax and obinutuzumab if they've been treated recently. And then some people got chemotherapy or chemotherapy with rituximab. Those aren't really a standard or preferred regimen these days, but people have gotten those back when it was. So there are some people that have not gotten any of our current preferred targeted agents because they were treated with chemotherapy a while ago. So this kind of helps us think about what treatments people might have had. And then this sort of represents kind of different treatments people might have experienced over their lifespan, starting at the top. So it used to be that patients were treated with chemoimmunotherapy, had some time in remission, the CLL would return, then they'd get chemoimmunotherapy again. Then shortly after that, we developed ibrutinib. So people get chemoimmunotherapy, have the CLL return, then get ibrutinib, which is a continuous treatment. Then we've kind of got this venetoclax rituximab scheme, which is a 2-year treatment. Some people actually at diagnosis would take a BTK inhibitor like acalabrutinib till they progress, then take a drug like venetoclax, which is a BCL2 inhibitor. So you can see, even though these are highly effective treatments, that's a lot of time on treatment. We also have a venetoclax obinutuzumab, early treatment, time off treatment, and then we don't know yet what is best after that because this is a newer regimen. We have a drug that was approved recently called pirtobrutinib. So the question marks are sort of areas where we don't know what's best. Ibrutinib and venetoclax is something that hopefully will be approved in the United States at some point. It's approved in Europe, but not the US currently. So there's a lot of options here is kind of the point. So this isn't meant to give an example of any particular treatment pattern someone needs to have or should have, but these are different ways to think about it and different ways that people might have taken treatments over their lifetime of living with CLL. And so we can talk a little bit about how one might choose between these things. and what's considered. So there's just a lot of treatments available in 2024 and more coming. And so when thinking about relapsed refractory CLL, some of the ways to think about it is how to select a subsequent treatment. And what's really the most important thing is what treatment was taken first. So if people got chemoimmunotherapy first, then actually all the options are open for targeted agents now, either venetoclax, which is a BCL2 inhibitor, or ibrutinib, which is a BTK inhibitor. So it really leaves the same variety of targeted treatments open that were kind of available in the first place. However, if people have been treated with one of the targeted agents, that really plays a pretty big role in selecting what they might do next as treatment once their CLL recurs or they need treatment again. BTK inhibitors are continuous therapy, so people take them indefinitely until it stops working or they have side effects and have to quit. So if they stop taking it due to intolerance or a side effect, you might be able to switch to one of the other available BTK inhibitors and do very well. However, if the CLL becomes resistant to a BTK inhibitor, switching to a different one of the covalent type, which is the original type, really doesn't work very well. So there are a couple options for things like venetoclax. I'm going to talk about these a little more. Pirtobrutinib and investigational treatment. But really going back to a covalent BTK inhibitor is unlikely to work or control the CLL. And then actually, if people took venetoclax the first time, those are usually regimens that people take for like a year and then quit taking the drug. So it's currently unknown because we've only been using these drugs sooner, but the limited data available suggests you can take the same treatment again or switch to BTK inhibitors. So there's a lot of options there. And then at the end, there's something I'm going to spend a little more time on, which is CLL that was either exposed to or resistant to these two major types of drugs, BTK inhibitors and venetoclax, because that really does need a very different type of approach. So while it doesn't matter as much which drug you take first, this is just an example of how drug resistance or having the CLL become resistant to a drug can impact the expected benefit of treatment. So I'm showing you here, these are Kaplan-Meier curves. If you haven't seen them before, oncologists love these because it helps us understand differences between treatments. And if you're looking at, you'll see there's one graph that has just one red line, and it's showing you something called progression-free survival. So the red line is the fraction of patients that are likely to be alive and without their leukemia recurring. And the median, which you can think of like an average, although it's really not exactly an average, is about 2 years. So that's showing you people who had taken ibrutinib who then took venetoclax. So the amount of time people can expect to be in remission is, 2 years, but it's not like all of them, have their CLL come back after 2 years. It's by 2 years, about half of them have either died or had their CLL return. So you can think of it as like an average benefit of 2 years. The other one I'm showing you, and you want to look at the blue line in this one. This is a randomized study of venetoclax taken, and this is a study for patients that did not have ibrutinib or a BTK inhibitor, which is like one of our classes of targeted drugs first. And here the median progression-free survival is not quite, but almost double. And that's actually only 2 years of venetoclax with an antibody medicine. So it's really showing you that once the CLL cells have become resistant to ibrutinib as a class of drugs or BTK inhibitors, the benefit that people get in terms of their CLL being controlled by venetoclax is actually shortened. And this is probably true the other way around too. It's just ibrutinib we've had longer, so we have more data in this area. But it really looks like whenever there is any treatment that the CLL cells have become resistant to, the other mechanism of treatment doesn't work quite as well or for as long in terms of remission. This is some data looking at sort of what I was talking about, which is taking, the other way around, the BTK inhibitor ibrutinib, taking it after venetoclax. This is a little complicated. This is a paper looking at a chart review of what happened to patients. So they had IRB permission to like review medical records to find out what was going on, and found out that like if people had never taken a BTK inhibitor or had stopped it for side effects, then took venetoclax and had their CLL come back, actually things looked pretty good. The ibrutinib they took worked pretty well. However, if they were resistant to it, they took venetoclax, still doesn't work very well, so it doesn't eliminate this resistance. But this is kind of showing you that, like, you can take ibrutinib after venetoclax or venetoclax after ibrutinib, and it works, but the benefit you get from either one you take second is going to be less. So, and then also once someone's CLL is resistant to a drug, that seems to be a permanent state that's not going to improve. Sadly, because that would be great if we could restore sensitivity to the drug. This is just for venetoclax retreatment. Again, since this is a newer drug, we hope in the future to learn exactly what people, can expect on average if they took a venetoclax treatment, finished it, had time off treatment, and took it again. I'd like to be able to tell my patients what to expect from that approach. Because these are newer drugs, we just don't have as many patients that have gotten to do the approach yet because they haven't needed it yet because they're still in remission after the first treatment or whatever. So it's something that we are hoping to learn in the coming years. There is a study that AbbVie, the manufacturer of venetoclax, is doing called what's actually called Revenge, because the drug regimen is called Benji, so it's like a clever name for the study. But they're actually literally looking at people that take venetoclax and a drug called obinutuzumab, have a remission, and then take it again. How well does that work a second time? So I'm really excited to see that result, and hopefully patients participate in that study, who would like to try venetoclax again, because I think that's a good idea. And we have a lot to learn from that. But it looks like if you take venetoclax again, the kind of benefit is also about 2 years. So you're kind of seeing this, after one treatment's been experienced, you see a shortening of the benefit from a second treatment, either with the same drug or a newer one. So what that's leading up to is that over time, the CLL cells, which are cancer cells, continue to break and acquire changes in them as they develop resistance to these drugs. And eventually, you've got a situation where the CLL cells don't respond well to our two best classes of drugs, BTK inhibitors and the BCL2 inhibitors, which the one we have currently in use is venetoclax. So people hear these terms like double exposed or double refractory CLL, and we don't have any standard definitions for this yet. So you always have to think carefully about, like, how is the person that's using those words using it. But in general, double exposed CLL means that a person with CLL took both the classes of drugs, BTK inhibitors and BCL2 inhibitors. So their CLL cells have been exposed to it. It's not clear whether or not the cells have become resistant to the drugs, but they've definitely had exposure to them. So resistance is possible or could develop. And then double refractory, usually the strict definition means that someone has CLL that's progressed while they were taking one class of drug and then the other, so both classes of drugs. Both these are associated with poor outcomes, and in general, people living with CLL can expect to live for many years and feel, well enough to enjoy their lives during most of that time, if not all of it. But this is really the group of patients where we have the most problems from CLL. And actually, this is the group of people where CLL might become something that shortens their lifespan, or they might die of CLL, because it really does kind of becoming resistant to these drugs makes the cells more aggressive. This is data from some Australians who did a series of looking at 17 patients in Australia. And this is, again, the study was published in 22, so it's a few years old before some of the newer drugs we have are available. But they found that for people whose CLL become resistant to, ibrutinib and then venetoclax, or even vice versa, and the order didn't matter, the average amount of time people live for, the median, which is similar to an average, was only 3.6 months, which is very short. We usually expect people with CLL to live multiple years. So this was very alarming to everyone in the field, to have a group of patients where maybe the average lifespan is only a few months, because that's not what we expect from CLL in most situations. So this also highlights just how bad this problem is. And the Australians used an extremely strict definition of double refractory. So these are literally patients who had the CLL increase or progress while they were taking these treatments. So they're not patients who like finished a treatment in remission, had time off treatment, and had their CLL come back. So just highlight, I mean, this is really closer to the kind of the survival expectation for an acute rather than a chronic leukemia. So there's a few things though that we learned that can really change this. And I've had patients here at Ohio State that I've seen do much better than this expectation, even after their CLL is double refractory. And that's really because some of the things I'm going to talk about next. But this does require a bit of a different approach, especially when this is something that is now like a more life-threatening condition. So in that same series, they did make this plot. It's called the swimmer's plot. So each of those numbers is one of the patients included in this analysis. And then the bar graph is kind of like over time and ones with the arrow are ones that are still alive. The ones with the dots are people who died. And you can see here there's two things where you've got a good amount of bar there. One is actually a donor stem cell transplant. So this is kind of the one situation where we would consider a donor stem cell transplant for CLL. That is a very intense treatment that is not suitable for everybody, nor is that something everybody wants to do. But then I was intrigued by looking at kind of these green bars here, and that's taking ibrutinib and venetoclax together. Um, we know that the combination is safe from other studies. This is not an approved combination, but it does seem to work reasonably well. And it's kind of a thing that we in the field don't really understand when you have cells that are resistant to ibrutinib and resistant to venetoclax, but you put them together and suddenly it works well is a very surprising thing. So we don't really understand the biology of why that happens, but we know that it does work. And that's really benefited some of our patients being able to use that combination for them. So there are strategies that can improve things. This is our data from here at Ohio State, looking at combining ibrutinib and venetoclax, and this is actually in double exposed. So it's for patients that took both treatments but didn't necessarily have their CLL become resistant. We had 13 people in this position. And the good news is at 1 year, 70% of people were still alive. So that's really good and is better than kind of what we're seeing with the Australian series. So this is effective, and we actually have some things that might even be a little bit better now that I'm going to talk about. Some of them are targeted therapies. So I've talked a lot about BTK inhibitors, but what I've really been talking about is covalent BTK inhibitors. So ibrutinib, zanubrutinib, and acalabrutinib, which are the approved covalent BTK inhibitors. And they all kind of work the same and have binding of the drug, which you can see in the graphic, to um, a same binding site of C481, which is just the amino acid residue. However, these cells can mutate that residue so that the drug doesn't bind anymore. There are some non-covalent BTK inhibitors. The two that are really the farthest in clinical development are a drug called pirtobrutinib, which has accelerated approval by the FDA, and then one called nemtabrutinib, which is in clinical trials. And those drugs, instead of binding to one site irreversibly, actually bind differently so that they can work even in the presence of these mutations that the CLL develops to outsmart covalent BTK inhibitors and actually bind and unbind BTK, which reduces side effects. So that's a very exciting way to treat CLL, especially CLL that's become resistant to BTK inhibitors, and it allows patients to continue to benefit from using that mechanism to control their CLL. These are something called maps. They look like feathers a little bit. So if you've never seen one of these before, the kind of feathery ends are different proteins, and the map is how similar they are to each other. You can see the one in BTK there. That's the target of pirtobrutinib. So pirtobrutinib, which is the one that is an approved drug, is very selective. There's like the one big dot for BTK. That's the one that's inhibited. And some smaller red dots are kind of like other proteins that it blocks too, but not as strongly. However, if you look at nemtabrutinib, there's a lot of red dots, so not just BTK, and those are all other proteins inhibited by nemtabrutinib. And while you might think that's a bad thing because you can get more side effects the more proteins it inhibits, we do think in some cases blocking these other proteins might help the drug work a little better. So it does have more side effects than pirtobrutinib, but in some cases we think there might be a benefit to blocking multiple protein kinases. Currently, that's theoretical. These drugs haven't been compared head to head, but I think that's an intriguing thing to think about. So pirtobrutinib, which I've been talking about, again, there's the kinase map where it's now gotten red the one at once, and then like the blue is ones that you don't really want it to hit. It's also got a little demographic of kind of like how it works. Um, this is a non-covalent BTK inhibitor, and it actually inhibits BTK and CLL cells that have mutated their BTK protein to avoid covalent BTK inhibitors. It actually binds that a little bit better than wild type, which is normal BTK. So it's actually kind of designed to work in this resistance setting. And it actually may inhibit some other protein interactions that we don't fully understand. I'm going to show you some of the clinical data with this, but this drug was so effective in this kind of double refractory or double exposed population that the FDA granted an accelerated approval for people that have already taken a BTK inhibitor and venetoclax in December of 2023, which is pretty exciting. We've had this drug in clinical trials too. So we'd been using it for a while for patients that participated in a research study, but it's nice to see that other people will have access to it as well at this point. This is just a snapshot of some of the demographics. This is public information from a meeting at the end of last year. This is the demographics of who participated in a large study with pirtobrutinib. And you can see that the kind of number of prior treatments was fairly high. I don't know if I have that one on here or not. Yeah, so uh, they have it broken down by what treatments people have had, but it's usually like a median of 4. So then they have 2 cohorts. They have people that took a BCL2 inhibitor and those who did not. But that's a lot. So these are people that have 4 different treatments in their lifespan already before being in this study. Some people had as many as 11 prior treatments. So in each treatment damages the CLL cells and can make them a little more aggressive. So then you can just kind of see a rundown of what treatments people have gotten prior at the bottom of the first panel. And so all of them had gotten a covalent BTK inhibitor and then a variety of other treatments too, including a fair number that got BCL2 inhibitor. And that's why they broke it down. This is venetoclax for the most part, like got venetoclax or didn't. So this is a very kind of high risk group of CLL patients where you know the CLL is going to be difficult to treat. And actually, we had a median progression free survival of 23 months for people that had not taken venetoclax before or a different BCL2 inhibitor, and 15.9 months for patients who had. So 15.9 months does not sound awesome. It would be better if it were 10 years, but in that original Australian series, people were on average only living about, like 3 and some months. So now we've got something that's, almost a year and a half of having the CLL controlled. So this is a huge benefit in this same group of patients who have taken like both our standard targeted agents. So that's actually quite good. The drug has a few side effects, actually. It's some of the same ones you see with the covalent BTK inhibitors, although to a less extent. And then you can see just these are Kaplan-Meier's again. They have it parsed out by like percent of people at those time points expected to be alive and with their CLL controlled. But the other thing that's cool that I like about this study is this is now showing you not progression-free survival, which is how long people are alive and in remission. This is overall survival, which is how likely people are to be alive at this point. And you've got at 2 years, either 83% for people that had not taken venetoclax or 60% for people who had are still alive. So that's really good. And I think, especially in that BCL2 exposed cohort, really much better. And this also, when you see a difference between progression-free survival and overall survival, means that people had their CLL return and went on to something else that was effective. So this is just kind of showing that some of these newer treatments have made a huge difference for this patient population. This is nemtabrutinib. This is the one that has like more targets. That's also a BTK inhibitor. I do not have as much data with this because it's newer, but these are just some response rates showing you that it actually works pretty well. You don't have a lot of, this is complete remission, but you can see the median progression-free survival in that same population is about 10 months and a little longer for people that hadn't had venetoclax. And that's good. This is a smaller study still because it's still in development. Here's just the Kaplan-Meier's to go along with that. And this is showing you divided by patients that's without mutation causing resistance to BTK inhibitors. So along those lines, we now have the covalent BTK inhibitors, non-covalent BTK inhibitors, and we decided that BTK, which is this like protein that's important to the CLL cells, is so important that we actually started developing something called BTK degraders to target this. So this actually removes the protein entirely from the cell by using like the cell garbage disposal waste management system. So these like actually get the cell to break down BTK protein and eliminate it. So that's pretty cool. And this should work in cases of these resistance mutations because again, you just need the cell to degrade or break down the protein. I'm showing you a diagram there of one called Protax, where basically it binds this complex that adds ubiquitin, and then ubiquitin is like a cell protein that causes the cell to go through like the cell's garbage disposal. So these are really cool. And I think this is a nice approach because you don't have to worry about the cells becoming resistant to it. It can just remove the protein wholesale. There were some side effects seen with this, and it's still really in a situation where they've got several of these drugs in development. They're trying to find the correct dose and figure out all the side effects and things like that. But people are already getting this drug in clinical trials and benefiting. And not just the one I'm showing you here, which is a Protac, but there's actually several. This is a little data that's been presented with a compound NX2127 by Neurax. It's just one of the BTK degraders in development. This waterfall plot where you see these things down here, those are people that had a reduction in their lymph nodes taking this drug. So it's exciting. And these, either this blue is like that kind of double exposed population where outcomes are usually worse. So it's cool to see that this is starting to work for people. I mean, again, we'll need more study and more information. But I like to see that that is going pretty well in development, just so there's more options out there in the future. So shifting gears a little bit to a completely new way to do it. Hopefully I've made my point that as you expose CLL cells to targeted agents and they become more resistant to and they become more aggressive, this is a method of getting the immune system to do the work instead. So that's great. Hold on. Sorry if you're hearing me cough. It's like my allergies are quite bad here. That's what happens when I talk for like 20 minutes. So this is like a way of getting your immune system to target the CLL so that they stop becoming resistant to these like different targeted therapies. And currently, these are mostly used in the double refractory setting because people do so well with these targeted drugs. You don't want to, do something that might, cause more side effects earlier in treatment. But these are antibodies that actually link the CLL cell, which is on there, is tumor cell, and a T cell, which is an immune system cell, and it's an antibody that binds both of those together and causes the T cell to attack the CLL cell. So it's really neat. It can result in very good remissions. The epcoritamab is the name of the one I'm showing you here. That's kind of in the middle between the cells there on the diagram. Epcoritamab is just one of these drugs that's in development that's been tested in CLL. This is not for free, so it can cause a lot of immune-related side effects. If you think about it, if you get some of your immune system cells to attack cancer cells, oh, sorry, you can end up with kind of like an immune overactivation called cytokine release that can cause problems. But this does work and is a neat new way to target CLL cells. And I look forward to seeing one, how well this works in more studies, and also if we can combine it with some of our targeted agents to result in even better outcomes. This is some of the limited data available with epcoritamab. This is a swimmer's plot where it just shows you the blue lines are how people were doing and how long they're on the drug, showing you quite a few responses. So time to response is pretty short, but the progression-free survival percent is 67% in 9 months. So not bad. Okay, and then this is something that's gotten a lot of press recently, called CAR T cells. I think most people have heard of this, and this is another like immune system targeting strategy, or getting the immune system to target the CLL. I'm showing you something. I'm going to show you data from something called Lysocell, which is a really long name. The abbreviated name is Lysocell, and these are cellular therapies. So they actually use someone's T cells to attack their CLL cells. So they take this T cells out of the blood, and that's through a process called apheresis. If you've ever seen someone donate platelets, this is how it's done. There's many other uses for apheresis, but they then take the T cells, engineer them in a lab to fight the CLL cells by sticking something called a chimeric um, T cell receptor on it. So that means the T cells are now designed to fight. The most common one and the one used for lysis is something called CD19. And CD19 is on CLL cells. So they engineer T cells to fight your CLL cells. This is a complex process that looks really simple when you see it on this diagram, where it's like, oh yeah, take the blood, isolate T cells, engineer them, make a CAR T, expand it, put it back in the body. But it does require high dose chemotherapy to prepare the body to accept the T cells back. And people can also become very sick after the cells are infused with cytokine release, which I'm not really covering today. This is just an overview of who was enrolled in this study, because a lot of them had double refractory CLL, the people who participated in this. But these again are more Kaplan-Meier for outcome. But the upshot here is the people that got the response we're really looking for, which is long-term control of the CLL, where the CAR T cells are actually keeping the CLL under control. It was 18%, so that's a little less than 1 out of 5 patients. So if you have 5 patients undergoing that whole process, you've got about 1 out of 5 that really gets that extremely successful outcome where they can be alive for years with their CLL controlled. Then you've got some people that get a year or two of benefit, and then some that really don't benefit very much at all. And then this study had 2 different populations, and the one side is really closer to the double refractory population, where you can see outcomes aren't quite as good. But this is something that absolutely can work in double refractory or double exposed CLL, but is a whole undertaking. So before I go into a few things that are on the horizon, which I think I talked about a bit of them, the reason I went through this, you're probably thinking like, okay, well then what should we tell people to do if they have double refractory or double exposed CLL? And there's not an easy answer to that, because some of this depends, like if people are open to doing something like CAR T cell therapy, which has a lot more side effects and a lot more treatment burden to go through, but can, if you get in the lucky kind of 1 out of 5, have the highest reward or success of long-term remission. Pirtobrutinib and actually liso-cel now have accelerated approval. But pirtobrutinib, which is a reversible BTK inhibitor, again, average amount of time it works for is a little less than 1.5 years, but that's just taking a pill without too many side effects. And then, some people are open to being in a clinical trial with, degraders, bispecific antibodies, or something else. So when thinking about what to recommend for someone with double refractory CLL, what their goals are in terms of how much treatment do they want to go through, how much, potential success do they want to have from that. And also like thinking about, okay, if this is going to work for 1.5 years, what maybe do we have to do next, I think is really important, because the BTK inhibitors and venetoclax as a first treatment usually lasts for much more than 5 years, usually more years than that. So you don't really have to think ahead right away as to what's happening next, but here you really do. And I think I covered some of these already, but I just wanted to cover this too, because I think that, these are things that people who have double exposed or double refractory CLL might experience a lot of these treatments. So I certainly was talking about combinations of BTK inhibitors and venetoclax, because even in resistance that works. There are some even newer BTK inhibitors in development. I had a couple slides on degraders, but there's ones like LP168, which actually has a dual mechanism. There's actually novel BCL2 inhibitors, so that's what venetoclax is. There's one that's in testing now called sonrotoclax, but it's not the only one. There's lifastoclax and oh gosh, I might have said that wrong, but there's some new BCL2 inhibitors in development. And then I talked about bispecifics and degraders. And then I talked about liso-cel CAR T, because that's the one that has accelerated approval. But there are more CAR T products in development, including some that aren't T cells. So there's like CAR NK cells and stuff. So I think that that's actually going to be quite interesting for the future. And then I think I had some things about clinical trial participation that you can read when you get the slides, but I'll skip that in the interest in time and just go over some take-home points, which I think I've mostly covered. But just the more treatments a person takes, the more likely their CLLs to become resistant. And then the more treatments people take, the more aggressive the CLL can become. So you really have to think carefully about, how many treatments someone might take in the coming years, what's likely to work well, and what they can do. And the whole goal, of course, is to improve treatments so that people can, continue to have a normal lifespan and take treatments that allow them to live their lives the way they kind of want. And I think people with double refractory or double exposed are really in a spot where we're not there yet with the technology that people are able to live as long as they would expect or as well as they'd want. So that's why it's a really important area. Um, so I can stop sharing the slides and take any questions if anybody has any for me.
Thank you so much for your presentation, Dr. Rogers. It was very insightful, and we're very grateful for your education and support. Like Dr. Rogers said, it is time for the question and answers portion of today's meeting. So if you have a question, feel free to either do so by typing it in the chat box or by raising your hand if you would like to speak. If raising your hand once you're called upon, you can then unmute yourself. So as the questions come in, Dr. Rogers, we did have a few pre-submitted patient questions. I'll ask one of those and then I'll get to Cindy's question here. So one patient is wanting to know, would you recommend trying, so they have been exposed to both venetoclax as well as ibrutinib, and they are now wanting to know, would you recommend that they consider a clinical trial first or opt for something that's already FDA approved, such as CAR T-cell therapy or pirtobrutinib?
Oh, that's a really great question. And I think the answer mostly depends on what clinical trials are available. And then, pirtobrutinib and CAR T are two pretty different things, right? One of them's just taking a pill and going about your business. The other is like a whole 2 month long process to get through that usually results in people being hospitalized. So that's kind of a discussion also based upon like how much, like care burden someone's willing to go through for an eventual uh hopeful good outcome, and then what people's health conditions are and if they're really like in good shape to go through a CAR T, because if you're already having a lot of health problems that could really make things worse for you. And so it sort of depends on what clinical trials are available. So some of the clinical trials, like a bispecific antibody, someone might want to try sooner because then you'd still have options like pirtobrutinib you could get that's approved if you wanted to do that after that. And the opportunity in a clinical trial to take a drug that might control the CLL using an immune approach with an antibody infusion could be really attractive to someone. But if you have clinical trials with things that aren't really suitable for you or the mechanism's not very interesting for your particular CLL, then you probably want to pick a standard one. So I always encourage people to participate in clinical trials because I think at least here at Ohio State, usually we're offering them something that has an advantage over the approved therapies. But you have to kind of know what your clinical trial option is before you make a decision on that versus standard of care. Hopefully, that's enough information to think it through.
Oh yeah, for sure. That makes a lot of sense. Thank you for answering that question.
Sure.
That was very helpful. Okay, Cindy, you have a question?
Yes, I've been treated with venetoclax and obinutuzumab 4 years ago. I've been 3 years off, and we've been using clonoSEQ to follow my progression. I was undetectable after treatment, and after 3 more years, I'm had a steady increase up to 1800 on my clonoSEQ test. And my doctor has suggested retreating with venetoclax as a single agent indefinitely. And I have no other blood work problems. My platelets have come back up. No lymph nodes, no spleen that I've noticed problems. But I kind of like the idea that she's starting a little bit earlier to manage the progression. I was wondering if you have any comments about that.
Yeah. Well, I think this is definitely an area where we could use some more information because You probably got venetoclax and obinutuzumab closer to the time that it was just approved. So since it works so well, we're only now starting to see people in your situation where the CLL is coming back after that. So that means we don't have a lot of like information on what happens to groups of people after this treatment because we've only started seeing people with the CLL return. That's why they're doing that study looking at repeating the same treatment of venetoclax and obinutuzumab. So I think it's not really known if you need to do obinutuzumab again or if you can just do venetoclax with it. So I think there's no right or wrong answer to that. And I do definitely think that if people did well with venetoclax the first time, repeating that type of treatment is a really good idea. And it also would leave the other class of drugs kind of open for use in the future, which would be BTK inhibitors. I do think it is a completely unanswered question whether or not one should really start early with this. So the standard that we've been doing is waiting until there's treatment indications again, right? Kind of like the first time, like low blood counts from bone marrow infiltration, lymph nodes, something to improve. You're talking about a strategy where you're looking at clonoSEQ and saying like, oh, this is now coming back and to do treatment before people are really having symptoms. I do think it's, more common to treat people earlier for like this relapse refractory CLL. But we don't know yet about the strategy of intervening before there's really much CLL. So that's something we hope to learn about. And so I can't really tell you if that's the best approach or not, just because we don't know. And I think, there's hopefully going to be more information on whether or not like treating earlier in that circumstance really helps people. I do think it's worth treating before people get actually sick or have a lot of symptoms from CLL.
Thank you.
Thank you for answering that question, Dr. Rogers. Cindy, I hope that answered what you needed.
Yes, thank you.
All right, wonderful. Okay. While we wait, if any of you do have live questions, feel free to either raise your hand or put those in the chat. We did have an additional couple just pre-submitted questions. And so an additional one was patient asked, do you know if patients are pre-educated about side effect management strategies before they receive the therapy to help reduce patient fear?
Yeah, I think they should be. Whether or not they are kind of depends on who they're getting their healthcare from. I certainly try to do this in my clinic is to tell people about one, the most serious side effects to look for, and also some of the common ones experienced. To some degree, you can't know every side effect a person could have. But I do think it's really important to talk to people about like the common or serious ones. I also like to break things down especially for the targeted agents in CLL. It's kind of like you get some people that get no side effects and kind of wonder if it's a real treatment until they see their lymph nodes and blood counts improve because it goes so well. People, which is most people taking these drugs, get some mild chronic side effects that they notice, but they don't really keep them from doing the things they want to do. So, including like, some of the BTK inhibitors can cause brittle nails or venetoclax can cause diarrhea, but it's not like diarrhea that makes you stay home from your work or your activities or whatever. In fact, sometimes it's just like, okay, people have looser stools, but they're still fine and do whatever they want, so it's a change, but it's not bothersome. And that's probably most people taking these drugs. Then there's people that get severe side effects that really do impact their lives. And in most cases, then we switch to a different treatment if that happens. If it doesn't get better, we can't, improve that otherwise. I do think people with double refractory CLL is probably a group of people that are going to have to tolerate more side effects just because the treatment options are more limited. But I think educating people just one on that the expectation is they should be able to live their lives pretty normally while taking treatment. I have a lot of patients that think, oh no, if I do treatment, I'm going to feel terrible for a whole year. I'm getting treatment and just have to take a year off from doing anything in my life. And that's not what we expect or want for our patients. So just setting the expectation that we expect they'll feel well most of the time taking treatment. And then definitely warning people about those kinds of side effects. Physicians do some of that education. Our pharmacists actually meet with the patients to go over education and they get written materials. And one place I've actually seen where patients get education about the drugs is actually from specialty pharmacies. So these targeted agents usually come from specialty pharmacies, and I've seen some of them get education from specialty pharmacies, which is cool. Some patients that are seen in my clinic are like, okay, yeah, I already talked to the doctor, one of the nurse practitioners, and the pharmacist. Like, thank you for telling me this fourth time I'm hearing it. But some patients who are, seen not at a huge CLL referral center, but in general practices, their, whole clinic isn't set up just for CLL. So I think it's nice that, they might not be able to provide the same level of education. So it's nice that specialty pharmacies step in there. And I've actually, some of the drug manufacturers have programs too to provide education on side effects. So I do think patients should be educated. It depends on where you're getting your health care, but I've really liked seeing that both specialty pharmacies and manufacturers have tried to fill that gap in some cases too.
That's wonderful to know. I didn't know about the specialist pharmacies, but
Yeah,
that is great. Yeah, definitely agree that the
yeah,
more education, the more
yeah.
fear is reduced.
And it depends on which one, right? So not all of them do
For
it or
sure.
do it as well, but it's nice to see that some of the bigger ones are definitely doing that. So
That's great. Wonderful. All right. Um, okay, we do have one additional pre-submitted question for our patient that lives internationally and was unable to be here. And it looks like you may have answered this one previously in your presentation, but if you could re-summarize here, that would be great. And so the patient is wanting to know, how do you manage side effects seen with pirtobrutinib?
well, that's a great question. So, I've used pirtobrutinib quite a lot, both when it was in clinical trials. I know someone asked me before, should I get pirtobrutinib or be in a clinical trial? And I say, well, it depends on what clinical trials you have. That before we had some of those drugs, clinical trials was really the best option. There weren't standard options that were highly worthwhile. So I was using a lot of pirtobrutinib in clinical trials, which helped people a lot. There aren't too many side effects, and most of the people taking it have already taken a covalent BTK inhibitor, which has more of the same side effects, the same type of side effects, but worse. So it's very uncommon that people have pirtobrutinib side effects that are needing to be managed, and it completely depends on what the side effect is. So someone that developed bleeding as a side effect that was life-threatening, I'm not sure that there's something that could be done other than stopping the medication. Certainly things like if people get like joint pain from it, sometimes magnesium supplements help. Sometimes, if people get like high blood pressure from it, which again with pirtobrutinib is not highly common, taking medications to lower blood pressure can help. So it really depends on what it is and how severe it is. But most of the side effects are managed by supportive care. So that's doing either more medications or treatments to try to deal with the side effect rather than stopping or holding the drug. The drug, you can reduce the dose of the drug, but if you do that too much, I kind of worry that you won't get enough inhibition of the actual like protein and it will stop working as well. So the majority of them are managed with what we call supportive care unless they're very severe.
Hey, that is good to know about supportive care. And thank you for your insight there.
Sure.
Wonderful. Well, I'm not seeing any additional questions, so we'll go ahead and wrap up here. Thank you again, Dr. Rogers, for helping answer questions and for your wonderful presentation. I do just want to let everyone know about a free resource available to you that we have here at HealthTree. So it's called HealthTree Cure Hub. You can securely connect your medical records, track CLL labs in one place, become a Cure contributor, and accelerate CLL research by participating in surveys, find clinical trials, and side effect solutions. You can access your free HealthTree Cure Hub account by visiting the link at the bottom of this slide. I'd also like to mention when our next CLL webinars will take place. On June 11th, we'll hear from Dr. Deborah Stevens about strategies to reduce and manage side effects from CLL medicine. On June 30th, we'll hear from Dr. Nitin Jain, who will share how often patients need common CLL tests. So to register for one or more of these events, please visit the link at the bottom of this slide. I want to take a moment to once again thank our HealthTree community for CLL sponsors, without whom this event would not be possible, Avi and Genentech. Oh yes, Cindy, you have a question?
If we're not able to be at the webinar live, where would we find a recorded video of it?
Great question. So we do record all of our events, and I will send in the follow-up email after this that you'll receive. I'll share the link of where you can view prior recordings. And yeah, as well, if you do register for the event, but you're unable to attend live, anyone that's registered, we send the event recording to in an email afterwards. I hope that answers your question.
Yes, thank you.
Okay, perfect. Well, thank you so much, everyone, for helping us build a strong HealthTree community for CLL. I appreciate you all. I hope to see each of you again soon. Don't hesitate to reach out if you do have any questions about HealthTree or upcoming events by emailing cll@healthtree.org. Thank you so much and have a great rest of your day.